Thank you, Joost, for the introduction. And as I said, we worked intensively during my time in Leipzig. And now to be actually reframing it, do you need to be actually in the low-risk candidate? Can a TAVI be implanted? That's probably the more probable question for this talk rather than a high-risk surgical candidate to be a TAVI candidate. So I'm going to probably touch on that a little bit. I have no disclosures. The objectives of this talk is presently to highlight the recent clinical trials, including the registries. And actually, I'm going to highlight a little of the latest results, which are really thought-provoking. And it actually, there's a paradigm shift from high to intermediate to low. I'm going to highlight on that. And what are the results and the future implications of these results? And are we at the transformation technology at the crossroad evolution of TAVI with surgical AVR? So these are the things which I'm going to touch in the next 20 minutes. As Jörg already showed, this the history. The first time, Professor Alain Crébière, cardiologist from France, he implanted it, and the patient unfortunately died 17 weeks due to a non-cardiac cause. And what's interesting at that time, this was performed during mild sedation and local anesthesia. So all the discussions which were ongoing, actually, in 2002, the first case was actually done under MAC. So let's all started after this. There was a huge number of trials, and these are ongoing trials. The first started with the partner trial, where there was a cohort A and a cohort B, and the cohort B in the symptomatic severe aortic stenosis patients, which were inoperable, were either transformed to TAVI or they were actually converted to standard therapy. This was the first cohort B, which was done, and the cohort A actually randomized the TAVI versus surgical AVR and the transfemoral versus surgical AVR. So these are like two cohorts of cohort A and cohort B. So this was published by Leon et al. in New England Journal of Medicine, and this was actually further formulated by two 5-year follow-up from Kapadia and Dr. Michael Mack, and they were the principal investigators, and they had actually shown from the conclusion from the partner trial that TAVR is actually superior to drug therapy in patients with severe aortic stenosis who were not suitable candidates for surgery. So in inoperable patients, actually, TAVR should be strongly considered. And it is, what is important, it is an alternative option for older patients with high risk of conventional valve surgery. But this was the time when TAVI was coming up, and there was all the usual caveats of the device, which was really high in size. I remember the time in Leipzig when we used to use the Ascendra device, which is 33 French, and now we use a device which is 16 French. So device iterations over time has actually decreased the risk of TAVR implantation. And obviously the experience is a learning curve from the surgeons and the cardiologists. There were a lot loggerheads at each other, and the transitions are actually really smooth now, and the risk obviously involved in the patients were really high. Then accordingly, parallel trial was going on from Dr. David Adams from New York. He published the CoValve US pivotal trial, and he actually showed the non-inferiority or rather superiority of CoValve compared to surgical AVR. And he also saw what was the safety and efficacy in extreme risk patients. So he concluded actually, and this is a very important conclusion, that safety and efficacy were proven in patients unsuitable for surgical AVR, like the really extreme risk patients. And in the high-risk patients, this is, I think, a really a thought-provoking conclusion. The survival at 1 year was superior in patients with CoValve compared to conventional AVR. So this actually trend towards superiority even in low-risk patients. So that is something which we have to consider. Like what Jörg already shown, this is the Gary registry from the surgeons, but this is an article from 2013, but this was a retrospective analysis of 13,680 patients. And what it did is actually change the risk profile of TAVR. Initially, the low risk were obviously more than 65% were converted to surgical AVR. The intermediate groups were really, it was a question mark with which phase it will go, whether it's the low or the high or the intermediate. And the TAVR in 2016, that actually the current TAVR is a equipoise between the surgical AVR and the low risk, which is still the gold standard, and it's dangling between the intermediate care and obviously the high risk AVRs are undergoing TAVR. So this actually started with, stimulated two major trials in the intermediate risk patients, namely the CERT-TAVI trial versus the Partner 2A. So they actually showed that the STS PROM score, like the predicted rate of mortality between 4 and 10, and Partner 2A had actually STS score of more than 4, and the difference between these two was, one was a global study, including US, Europe, Canada, and